he has broad-based gait, shuffling gait over the past few months. He also has urinary incontinence, increasing apathy, and forgetfulness. Examination shows a magnetic gait, but no focal neurological deficits. What is the most likely diagnosis? So again, um, uh, okay, now this is a question. This can be, that can uh, sort of give you various diagnoses, but mainly the point of this question is it sort of gives a constellation of symptoms again, because in all of medicine, on all of these things, you might not be able to work out every question. So sometimes it's all about pattern recognition. So in your questions, you just try to see for a constellation of symptoms and try to put it into like a pattern. So in this case, you have a proper pattern or constellation of symptoms. Again, a triad, which is urinary incontinence, which the patient has, and forgetfulness and apathy. So like sort of like neurological symptoms, like what you call dementic sort of symptoms, or like dementia. And also they have broad-based shuffling gait. Okay, they have an ataxic sort of gait, so gait abnormalities. So again, a very famous sort of triad. This triad leads to normal pressure hydrocephalus. Not any of the Alzheimer's or any psychiatric diseases. This is normal pressure hydrocephalus. Okay, something which you can't work out actually, so you should know it. Know this because can be asked in the exams. Okay, a very famous question. Repeat it because just wanted to refresh your memory on this. Okay, all right. So then we'll come to the next question again. Constantly being asked. Let's take mm, yeah. Okay, so again, this organ of toxic drones. Toxic drones is very important. Should know it in and out before we go to MCQs. And I've sort of put this thing so you can read it. So he sees a 29-year-old farmer is brought to the emergency department after collapsing on the field. On arrival, he is confused, sweating profusely, drooling, and has pinpoint pupils. Clothes are soaked, and he has wheezing, low heart rate, and diffuse muscle fasciculation. So he's wheezing also. Which toxidrome best explains this presentation? Now, if you see this, so now this thing starts from patient agitated or patient is drowsy. Okay, so patient agitated or patient drowsy. Now in this case, the patient is confused and not collapsed and all. So it's not going to be any sort of anticholinergics or sympathomimetic or serotonin syndromes. They are out. Okay, so when you do this sort of questions, you should have like a flow chart or something in your head. So a patient who is drowsy or confused, it could be from that itself, you should know that it should be with opioids or sedatives or cholinergic syndromes like organophosphate poisoning. Okay, so now the next step is so the neurologic patient is solemn, and this the blood pressure, pulse rate, they can be variable. They could be low, they could be normal, even though this graph says uh normal BP in the top ones and the low BP in, but it's variable. And the respiratory also, as you can see, it's depressed in all three. So usually you can't use it. But one thing to differentiate this the pupils. Yeah, this is normal sized pupils. Whereas these two are pinpoint pupils. The pinpoint pupils is opioids and cholinergic. Right? So patient who is drowsy with pinpoint pupils, a patient is drowsy with pinpoint pupils. Yeah. This is confused and pinpoint pupils. Can easily go into opioids or cholinergic. From those two in itself, you can come to those two. Now we need to differentiate if it's opioids or it's cholinergic. In opioids, they don't have a lot of secretions. They're okay. Like in contrary, we have cholinergic toxidromes like organophosphate poisoning. So what happens in organophosphate poisoning is basically you have this the organophosphates are actually drugs given for mycelium gravis. That organophosphates are like as they are acetylcholine esterase inhibitors. They irreversibly inhibit the acetylcholine esterase. So therefore, there will be a lot of acetylcholine. So when you have lots of acetylcholine, that means your neuromuscular junctions are working. That means a lot of secretions are going to come. Everything is going to be haphazard. So wet skin and diaphoretic, you have a lot of profuse sweating uh, and everything. So that's why this question says here diffuse muscle fasciculation. So diffuse muscle fasciculation, right? Because there's a lot of transmissions, neuromuscular junctions are working very fast and all. And then uh, here wheezing. Why wheezing? Wheezing means when you have a lot of secretions in your lungs are narrowed, so then you will get this high pitched musical sound in on inspiration and expiration. Okay, on actually on expiration. So again, why? Because the narrowing. Why? Because there's a lot of secretions. So again, coming to this question, patients confused and pinpoint pupils, it's going to be a patient who is opioids or has organophosphates. And how to differentiate those two is by looking at the secretions and features of muscle overactivity. If there's a lot of wheezing, if there's sweating and all, that means there's a lot of secretions happening. That is more likely to be organophosphate poisoning. Whereas if the patient did not have those kind of symptoms, that's more likely to be um, opioid toxicrosis. If they had normal pupil size, if the pupil size was normal with the drowsy and normal, that means usually you can get it in things like alcohol. This is the sedative hypnotic toxic drug. Okay, so those are the three things. If the patient is drowsy, but if the patient is agitated, that means there's only going to be like mainly it's going to be anticholinergic toxidrome and sympathomimetic toxidrome. How you can differentiate the two is in anticholinergic toxidrome they will be dry. So that's why you have this red as beet, dry as bones, blind as bat, mad as hatter, hot as hair, and full as flesh. So how you differentiate the patient is agitated, you know that there's no point of looking at the dilated pupils because both of the conditions will have dilated pupils. So if the patient is agitated, the next thing you look is if the patient has dry secretions or wet secretions. Wet skin, like if the patient is not sweating, if the patient is agitated and it's very dry, then it's more likely to be an anticholinergic syndrome. And in the anticholinergic syndrome, you will have like features of antihistamines, TCAs, atropine, and antipsychotics. So they are the examples of anticholinergic syndromes. Sympathomimetic syndromes, the cocaine, amphetamines, all the party drugs, they come under sympathomimetic toxic syndrome. Opioid toxic syndrome is usually opioids. Sedative is alcohol, benzodiazepines, barbiturates, and cholinergic syndrome mainly it's going to be opioids and organophosphates and pesticide. And neostigmine that is come here, but if it's given in overdose, that will give rise to cholinergic syndrome. Okay. All right. So I hope y'all get an idea. So can't remember this for a long time. So just remember those small points which will help you to get into an answer. Because these are commonly asked, they can turn it around anywhere around. Okay, so if you know it about this. So just remember that shortcut. Okay. All right. Okay. So helpful, but I took with RBS of 455. On examination, she was dehydrated, pulse rate was 100, BP was 100 by 70, which was the following is the first step in the management. So as you know, this patient is dehydrated, RBS is 455. So ideally, this patient might be in, so the main thing which you're worried about in this sort of patient is diabetic ketoacidosis. So diabetic ketoacidosis management per se is a long thing, but the main thing or the main paramount principles of management of patient of DKA is fluid resuscitation. Because what happens is in a patient who has DKA, they have osmotic symptoms. There's osmotic diuresis and all. So they are dehydrated. They are mainly dehydrated. And this question also says that she was dehydrated. So always the first step of management of patient with dehydration, uh, or in this case now you have to go with the ABCD management, no? So you have to start with A, B, C. So we don't have any features of A, B. So C is circulation. We have to get up to wide bore cannulas and we need to fluid resuscitate the patient. And only after doing that do we go for insulin. And also for insulin, we should go for IV insulin with potassium replenishment. So those are the main three things in DKA management. You have to do the investigations as well. The investigations mainly are you should do the urine ketone bodies and blood ketone or urine ketone bodies with the bicarbonate levels. That will give a diagnosis of diabetic ketoacidosis. Then you need to go ahead with the fluid resuscitation and do IV insulin management with potassium replenishment. So I think that should be enough for like for an SPA point of view. So the most important thing is you need to fluid resuscitate the patient. So in this case, you should give the patient IV normal saline. Okay, so that is this. All right, that's it. Because yeah, as I mentioned, uh, there's no organomegaly and all. All right. Okay, go to the next question. Um, A 55-year-old male who is a diagnosed patient with rheumatic heart disease presented to her routine clinic. On examination, he has an irregular pulse rate of 160 beats per minute, blood pressure of 120 by 70. What is the most appropriate management for this patient? So guys, you all should know now, rheumatic heart disease patient with an irregular tachycardia. So that in itself says the diagnosis. The patient is having atrial fibrillation. So atrial fibrillation, I know that the what you call the management of atrial fibrillation has been very confusing up until now. But now the guidelines have now switched to that. Initially there was this rate control and rhythm control. So meaning why? Because when you have a patient with atrial fibrillation, so basically we've spoken about atrial fibrillation in the previous questions as well. The atrial fibrillation, the heart is not contracting properly, it's just fibrillating like that. So then what happens is there's going to be clots formed inside. So suppose what will happen if you sort of correct the rhythm um, in a patient who has clots inside, what will happen is once you correct the rhythm, then the clots will just shoot up and then cause strokes. That's why we also mentioned about this Chadbasco and the need for anticoagulation and all. So those days there were various cutoffs to say, okay, if this patient, but sometimes if the patient has been on anticoagulation for some time and all, then we take the chance and go for rhythm control, where we can do DC cardioversion, or we can also go for chemical cardioversion, which like amiodarone and things like that. But now the newest guidelines say there is no place for rhythm control at the onset or at the diagnosis or treatment at the start. It's always going to be rate control. So rate control is only going to be either calcium channel blockers or beta blockers. Calcium channel blockers or beta blockers. Okay, so or just remember that. Okay, now it's very simple. For atrial fibrillation, now there's no rhythm control. Rhythm control is not there, at least not at the start. So it's in the rate control. Rate control can be CCBs and beta blockers. So now suppose the patient had like features of heart failure and all, then you can go for beta blockers. If the patient did not have heart failures, you can go for CCBs. Okay. So in this question, the question says that the only thing which has beta blockers is propranolol. So propranolol is going to be the answer. Okay, so amiodarone, DC cardioversions, yeah, they might have had a place uh, before, but now it's not there. It's mainly rate control, and after rate control has been achieved and all, and during the later stages only after consultant inquiries and all only you go for rhythm control, which won't be asked from us. So if you have been asked any question on atrial fibrillation and in a patient who is now in this case they are stable 120/70 plus rate is 160 and all, but if the patient was unstable then there's no argument, you have to go for DC cardioversion. Okay, so if the patient, suppose this blood pressure was like 90/50, that means the patient is shocked, meaning the patient has to undergo DC cardioversion. But the problem with DC cardioversion means, as I mentioned, the rhythm will come back to normal. So if there's a clot inside, it will shoot up. So what you need to do is in the emergency setting, when the patient comes to a 90/50 sort of blood pressure, and you give DC cardioversion, you are supposed to anticoagulate the patient before you shock the patient. Okay, so you have to anticoagulate the patient. You have to give heparin at the time you give the DC cardioversion. Okay, that's important. Okay, so that's just another way of how this question can be asked. This is a stable patient, atrial fibrillation. We go for propranolol or a CCP like amlodipine or anything like that. Rate control. Okay. Okay. So next one, question. A 45-year-old man, after long air travel, presents to the emergency department with sudden onset shortness of breath, rheumatic chest pain, mild hemoptysis. On examination, he is tachycardic, hypotensive, and has distended neck veins. Uh, Oxygen saturation is 85% on air. What is the most appropriate next step of investigations? So in this case, now it's very obvious. Now this clinical picture, patient who is having a long air travel and then shorts of breath with hemoptysis and pleurotic chest pain. It's very suggestive of a pulmonary embolism. So when you take a pulmonary embolism, guys, so it's important that you know a bit about the pulmonary embolism because it could be asked a lot in the MCQs as well as SPAs. So there are two ways you manage this pulmonary embolisms. Okay, so depending on the patient's condition. So now just look at this as suspected pulmonary embolism in a patient with hemodynamic instability. So, when a patient is having an instability, what that means is, so you have, okay, so you have the pulmonary arteries going like that. Okay, so if there's a massive pulmonary embolus here, what will happen is there won't be blood coming back. There won't be blood coming back into the right atrium, left atrium. Right, because there's no blood going beyond this point. Yeah, so that is what will give us this hemodynamic instability. A patient who has a pulmonary embolism, how the patient can get an hemodynamic instability is if there's a huge embolus here. So then what happens is the blood from the right atrium, this is going to be blue blood, so it's going to be deoxygenated blood going like that, and it can't get through that, so there won't be blood to come back into the lungs, back to the heart from the lungs. So that is what. So that is how a pulmonary embolism can cause hemodynamic instability. So what you are going to do is you are going to do an ECG, and the main thing is you do a bedside echo. You do a bedside echo, and when you do a bedside echo, you see for this right ventricular strain. Okay, you look to that. So if there's a right ventricular strain, you sure shot know that you are dealing with a pulmonary embolism. You don't have to go and do CTPA, which is the what you call the gold standard of pulmonary embolism or the management of pulmonary. So the what you call the mainstay gold standard diagnosis. You don't have time to do those, and also you don't need to do those because when you see a patient who's coming with a pulmonary embolism, who's collapsing, if the patient has right ventricular strain, you know for sure that there's a emboli in the pulmonary artery. Okay, so that's the main thing I wanted to get from this question. So here say, so now in this case, uh, I have excluded ECG, but if ECG was here, then you should do the ECG, because ECG will also show you, it will exclude ACS, and also you look for the right ventricular strain pattern. There's something called the right ventricular strain pattern. They won't ask what is that, but do have something like that. And then the bedside echo will also give rise to this right ventricular dysfunction. So you don't need to do venous duplexes of the legs or D-dimers, which is usually done, and CTPS. They are not needed. They're actually needed in the patient who is like suspected to have pulmonary embolism without a hemodynamic instability. So then you can use the modified Wells criteria. You have enough time, and then you can go and do the D-dimers or the CTPS. If there's high likely, let's go to CTPS, and if there's not, then go for D-dimers. You know why? D-dimer again is a investigation with negative predictive value, because if it's negative, that means there's no pulmonary embolism at all. So then you don't do it. And if there's CTPA, then you have to go for. So basically, to treat for pulmonary embolism, you need to you need to prove that there's a pulmonary embolism in the patient who is hemodynamically stable. Okay, so here this is CTPA, CTPA. So to do a confirm that, then you can go for anticoagulation. So anticoagulation can be done by enoxaparin BD dose. Okay, enoxaparin BD dose of 1 milligram per kilogram BD dose. But this case, so in this case, I'm stressing on is this patient is tachycardic, hypotensive, meaning the patient is in shock, basically. So in that case, you don't have time to do CTPS, D-dimers and all. So in this case, you should go for an ECG and a 2D echo. This ECG has been deliberately taken out so that because I want to stress on this 2D echocardiograph. So in the 2D echograph, you see for the right ventricular strain, and the right ventricular strain will then will be used to diagnose the pulmonary embolism and treat it there. So if you have a massive thing, then the drug of choice is um, tenecteplase. Okay, you need to go for thrombolysis. If it's not, if it's just a normal pulmonary embolism, you can just go for anticoagulation by enoxaparin BD dose of 1 milligram per kilogram. Okay. All right. So that is what I wanted to explain from that. So it will depend on the clinical scenario, how the patient presents to you. Okay. Snake bites has progressive slurring of speech with bilateral ptosis. There's fang marks on the left ankle. Urine output is satisfactory with urine analysis showing 12 to 20 moderate fields. What can be the snake? So most important thing is you all have seen this ptosis is there. Ptosis means there's a neurological deficit. And then there are fang marks also. There's a skin sort of reaction also. Fang marks seen in this skin reaction is also present. His urine output is satisfactory. Urine analysis shows 12 to 20. So don't confuse these two guys. So urine output is normal means the kidney functions are relatively okay. It's not the hematuria. It's like the urine analysis shows 12 to 20. It's also not seen the red RBCs. On moderate field means there's some sort of coagulopathy. It's not AKI because the urine output is normal. Okay. So now for this also we have a sort of an algorithm. Just look at this. So now this is marked local swelling. So if there are fang marks and if there are a lot of local swellings, it goes on the both sides. And then there are neurotoxic signs also. Neurotoxic signs, no, it's the patient had ptosis. And then there is bleeding. So in a cobra, you don't have bleeding manifestations or renal failure. Okay. They will just have less local symptoms and neurotoxic signs. Now in this question, so this patient had fang marks, and there was some sort of a clotting mechanism, clotting bleeding also, and then uh, uh, and then what you call, yeah, so this is neurotoxic sign. So here it's going to be towards the Russell fiber. So if you take the other part, this just for the completion's sake, uh, So here there's marked swelling. Yes, it could be still applied to this patient. And there's clotting. Clotting mechanism problems are there, but neurotoxic signs are not present. So in hump-nosed and slow-scaled, no neurotoxic signs. The vipers, they will have acute renal failure. So acute renal failure will be seen in hump-nosed, acute no renal involvement is slow-scaled. But the striking thing is both of these vipers won't have neurotoxic signs. So if you have neurotoxic signs with like renal failure or coagulatory problems, it is going to be Russell's. It doesn't have to be that. Russell's doesn't have to be all have acute renal failure, coagulopathy, and neurotoxic. All three doesn't have to be there. It's not, don't have to be there. So again, to sum it up, neurotoxic signs with local swelling, with no clotting mechanisms is cobra. Neurotoxic and coagulopathy with renal problems is going to be a viper. uh, clotting problems with local swelling, clotting problems without any neurotoxic signs, it's going to be either hump nose to slow scale in those two. So the hump nose will have renal failure, but slow scale won't have renal failure. So in the middle, you have the crate and the sneeze snake. So the crates, they won't have like fang marks and everything. The crate is just like the snake, but it won't have like marked local swellings. Okay, don't have marked local swelling. So yeah, so this is the sort of algorithm you need to think when you deal with cobra bites, snake bites. Okay, so in this case, the mass matching is going to be Russell's viper. Okay, to the hematology clinic, has headaches and dizziness, unfortunately suffered a myocardial infarction, so there's some sort of a thrombosis, you've been buying antihistamines, and because of the increased itching following a bath. So there's increased itching following a bath. He's a non-smoker. Okay, he looks plethoric with ruddy complexion, and you notice splenomegaly on abdominal examination. So hemoglobin is high. Others are usually okay. No? They're all right. So again, if you know this, if you've seen this, you know this, what the answer is. So one is the aquagenic pruritus. Aquagenic pruritus. And this HP level is high with splenomegaly. And this is a 72-year-old female, like an old male with aquagenic pruritus with HP high and splenic, and then also myocardial infarction, meaning there is like sort of thrombosis or features like that. So this again is a constellation of symptoms. If you know it. So it's polycythemia rubra vera. Okay, polycythemia rubra vera. I think it's an easy question. Just just again, don't be scared of these big questions. Just look for the key. It's just very small uh, hints given in the big thing. So just read it carefully, and then you can get the answer. Okay. So aquagenic pruritus, just remember that. Okay, this is very striking just for uh, polycythemia rubra vera. Okay, and then the next question, regarding hypothyroidism. Primary hypothyroidism is most commonly caused by Hashimoto's thyroiditis. So this is true. So you all know you have primary endocrine disorders and secondary endocrine disorders. So let's take hypothyroidism. So primary means the thyroid gland. The gland can't function well. So therefore, it's a primary issue in the gland. And secondary means something up, or signaling thing is not coming. That means basically signal. What signals the thyroid is a TSH. So it is secreted by your pituitary gland. So therefore, when the pituitary gland is not working, your TSH will be low. And then when is TSH low, then your thyroid can't work, leading to hypothyroidism. That is called secondary hypothyroidism. When the thyroid is not working, that is the primary hypothyroidism. So primary hypothyroidism is most common caused by Hashimoto's thyroid. That is true. Usually those days it used to be iodine deficiency, but now with iodine being included in the salt and all, now it's been taken off. So now it's going to be Hashimoto's thyroiditis. Okay, Hashimoto's thyroiditis. So then that is true. TSH is low in secondary hypothyroidism. That is also true because I told you TSH is formed by the pituitary. So if the pituitary is not working, that means TSH is not going to come. And as I mentioned, it's an upper signaling place. So the pituitary, then the thyroid. So hypothalamus, pituitary, thyroid. So actually, if the pituitary is not working, that means if the problems at the pituitary, that means it is secondary hypothyroidism. That is true. Cold intolerance, weight gain, constipation are classical symptoms of hypothyroidism. That is true, and I'm pretty sure you all got that right. And the exact opposite is true for hyperthyroidism. Levothyroxine therapy should ideally be taken on a full stomach for optimal absorption. Wrong. It usually is taken 30 minutes in the morning before your breakfast. It should be taken in an empty stomach. Okay, be taken in an empty stomach. And again, a practical point. And then hypothyroidism can cause bradycardia and diastolic hypertension. That is true. Okay, is true because hypothyroidism basically it causes it sort of causes bradycardia, means reduces the heart rate, and this diastolic hypertension meaning so diastolic hypertension mean like in the your pulse pressure will be narrow sort of. So again, feature of hypothyroidism. Okay, so again can come down. All right.